My name is Caleb Ng, and today I'll be speaking about a behavioral phenotype in clinical studies of anesthetic neurotoxicity. I do have some funding, but I have no other financial relationships to disclose. So if you were to look at many of the review articles and the editorials that summarize the clinical evidence of anesthetic neurotoxicity, many of them will say that the results are mixed or ambiguous or unclear. And the reality is that it's complicated. There have been over 100 clinical studies that have been published evaluating neurodevelopmental outcomes following exposure to anesthesia in children. Hundreds of different outcomes and outcome scores have been used. And there have been many different patient populations that have been evaluated, including different types of procedures, numbers of exposures, ages of exposure, and ages of evaluation. So I'm going to talk a little bit about some of the studies that have been published and some of the heterogeneity between the studies evaluating behavioral problems. The first study that evaluated behavioral problems in anesthetic exposed children was one looking at monozygotic twins where they're exposed under the age of 3 years old and matched to twins who are unexposed. They looked at the Conners teacher rating scale, which evaluated externalizing behavioral problems and found no difference at 12 years. Stratman published a study in 2014 where they evaluated 28 children exposed under the age of 1 year compared to 28 children unexposed and found no difference in the child behavior checklist, which is a commonly used survey filled out by caregivers evaluating behavioral problems in their children. So those two studies found no difference, but you contrast that with these two more recent studies published in 2015, looking at 35 children who had multiple exposures compared to 35 healthy unexposed children enrolled from a vaccination clinic. And what they found was that by using the CBCL 1.5 to 5 year assessment, so the CBCL adapted for younger ages, these children who are exposed with multiple exposures had 11 times the increased rate of having anxiety and depression problems as the unexposed children, and 8 times the increased rate of having attention problems. Another study in 2019 by Coach Fee evaluated kids who had a general anesthetic at their institution versus a regional anesthetic, and they used the IARS Child Behavior Inventory Questionnaire, which also evaluates externalizing behavioral problems. And what they found was that the kids with a general anesthetic had a 7 times increased odds of having behavioral abnormalities. So you have 2 studies finding no difference and 2 studies finding a major effect. So how do you interpret that? So we recognize that there is so much heterogeneity in the literature that we tried to perform a meta-analysis to try to interpret the results. We tried to focus on the clinical neurotoxicity studies that we felt were using the most comprehensive battery of assessments and performed prospective outcome assessment. And the reason why we did the focused on prospective outcome assessment were that these studies allowed the designing of batteries to involve the most sensitive outcomes, and also allowed for the review of clinical data in order to minimize confounding in that these children were physically evaluated by the researchers. We focused on single anesthetic exposures and excluded children who were participating in studies of major chronic conditions, specifically studies evaluating kids with major congenital heart surgery or prematurity. And by using these inclusion and exclusion criteria, we found 3 studies that met criteria and had overlapping outcomes. These 3 studies were the PANDA study, which is a multi-center ambidirectional study evaluating kids who had hernia surgery under the age of 3 compared to siblings who didn't. The MASK study, which is a single center ambidirectional study evaluating kids who had various surgeries under the age of 3 compared to kids from the community who didn't have anesthesia or surgery. And these are both observational studies. And finally, the GAS trial, which is unique because it's the only international blinded randomized controlled trial that's been performed evaluating this question, where they randomized kids to having sevoflurane general anesthesia compared to kids who had hernias under awake regional anesthesia without sevoflurane. So when combining the data from all three studies, what we found was that there are 5 outcomes that they had in common. The first was intelligence as measured by IQ. We found no difference in IQ scores with a single exposure in these 3 studies. And here you can see that the I-squared is 0, which means that there's very little heterogeneity between these study results. And you can see that the results are completely overlapping between the 3 studies. The next score was the CBCL, which is composed of the total behavioral problem score, the externalizing behavioral problem score, which evaluates externalizing problems such as disruptive behavior and ADHD, the internalizing behavioral problem score, which evaluates problems such as anxiety and depression. And in this CBCL assessment, what we found was that there are higher or worse behavioral scores after a single exposure of about 2 points, and that the size of the association was similar in all 3 studies, with I-squares of 0 showing very little heterogeneity between the study results. Finally, we evaluated the brief, which evaluates executive function problems. And in this assessment, there are higher or worse executive function scores. However, this wasn't statistically significant after multiple comparisons adjustment. And also there's a little bit more heterogeneity in this result compared to the other behavior and intelligence scores. So the take-home points from this are that it seems that the behavioral results from studies using prospective data are a little bit more consistent than some of the other studies that have been published using pre-existing observational data. In interpreting this 2-point difference, we did a secondary analysis and we found that this was associated with about a 47% increase risk in internalizing behavioral problem in exposed children, which is far lower than the 7- or 8-fold reported in some of the other studies. And finally, that there are associations seen in some of the outcomes, such as behavior, but not in some of the others, like intelligence. So how does this compare to other studies? So this is another study that evaluated behavior in addition to a range of other neurodevelopmental outcomes in children from Southwest England, born from 1991 to 1992, where there are 1,000 kids with a single exposure and 200 kids with multiple exposures, compared to a large group of children with no exposure. And in this study, they evaluated a range of different outcomes and found differences in socio-behavioral outcomes with a single exposure, as well as multiple exposure, some motor differences with single and multiple exposure, as well as some differences in language here with a single exposure. But they didn't find any differences with these educational or cognitive outcomes. We did a study recently looking at prenatal exposures. And the reason why we did this is that what's unique about prenatal exposures is most postnatal exposures stem from the child's medical issue, which requires the child to have some type of surgery or and anesthesia. However, with prenatal exposures, it's a little bit different because the exposure is due to a need in the mother and not a medical condition in the child. The limitation of looking at prenatal exposures is that they're quite rare. In this cohort of about 2,000 kids, we only found 22 kids with a prenatal exposure. But in evaluating these kids, what we found was that their scores for behavioral problems were much worse, 6 points worse than the kids who were unexposed. However, this difference was isolated to externalizing behavioral problems, and we didn't find any differences in the other neuropsychological tests. Incidentally, this cohort was also evaluated for postnatal exposures under the age of 3 years old, and no differences in CBCL were found, but there were differences in language and abstract reasoning with the postnatal exposures. So I guess the take home from these two studies looking at a wide range of different outcomes is, again, that associations are seen in some outcomes, but not others. So it's likely that if behavioral problems actually do exist, then they don't exist in isolation because problems, neurodevelopmental problems usually co-occur with other problems. And one of the issues that commonly occurs with behavioral deficits is diagnosis of ADHD, particularly if kids have externalizing behavioral problems. So there have been a number of studies that have evaluated ADHD. And these three studies found ADHD only associated with multiple exposures. We performed a study using children in Medicaid, finding that with a large cohort of about 40,000 exposed kids, there was an increased risk of ADHD and ADHD medication use with a single exposure. And this study, looking at 30,000 kids, found there's, again, an increased risk of ADHD diagnosis with single and multiple exposure. And when you try to look at the consistency between the studies, you can see that overall single exposure is associated with about a 30 to 40% increased risk of ADHD. And multiple exposure is associated with a higher risk of ADHD. So to try to summarize and talk about where we go from here, there is some significant heterogeneity in the clinical studies. Some studies have found that exposure to anesthesia is associated with deficits in only specific neurodevelopmental domains, and behavioral problems is one of them. Nearly all of the studies are observational in nature and almost certainly have some level of unmeasured confounding, and as a result, the deficits we see may still not be due to anesthesia specifically, but could be due to another factor. If behavioral problems are present, they likely co-occur with other deficits. So we may want to look at some other potential deficits that are likely to occur with behavioral problems if we want to evaluate behavior. And finally, if we want to try to assess whether or not anesthesia really causes problems in children, we will need more observational studies and likely randomized controlled trials in the future. Thank you for your attention, and I'm happy to take any questions.